Okay, I'm going to give it a couple of minutes while everybody's coming in, and then we'll run through the rules of engagement for tonight's webinar.
Great.
Okay. So tonight's rules of engagement are, this webinar is being recorded. No one can see that you're attending unless you would like to ask questions. So if you would like anonymity during the question and answer, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you all as possible, so please do ask your questions. Type the questions in the question and answer section. Please direct the questions to the panelists only, and start with the name of the panelist you are directing the question to. This is very important tonight as there are two specialists on the panel. Please direct PCOS questions to Dr. Patel and endometriosis ones to Dr. Heylen. You may ask questions at any point, but they'll be answered after all of the talks. If we don't get through your questions in the allocated time, which is an hour, we will answer them by email after the session. Remember, this is our beloved South Africa. So if there's load shedding or dodgy internet connection, please just bear with us. We'll resume proceedings as soon as possible. Here's tonight's agenda. I'm going to be doing a short introduction. Dr. Razina Patel is going to be talking on PCOS. Walter Mbatha is going to be talking, then Dr. Sulaiman Heylen. And then we're going to have the question and answer session. We're wrapping it up at about 5 to 7, finishing off at 7. So thank you to the sponsors for helping us to educate the public about infertility. The support helps us to break the silence, but it doesn't constitute an endorsement of any product or service by IFAASA, House of Fertility, or any of our speakers. Tonight's proudly sponsored by 360 Biomedicine, and they are also our headline sponsors for the whole week. Okay. Thank you to everyone for joining us tonight on day 3 of the inaugural National Infertility Awareness Week, South Africa, where we will be talking about female infertility, focusing on PCOS, which is polycystic ovary syndrome, and endometriosis. My name is Saskia Williams, and I am the founding director and CEO of IFAASA, which is the Infertility Awareness Association of South Africa. And we are bringing you this week in association with House of Fertility. IFAASA is a non-profit company that was established in 2013 to break the silence around infertility in South Africa, to educate the general public and to advocate the medical aids for fair cover for this prescribed minimum benefit disease. One of our key messages has always been to encourage people, women in particular, to take charge of their fertility. Knowledge is power when it comes to being on a journey when you have to relinquish so much of the control that we like to have over our lives. So well done for being here tonight, for empowering yourselves, and for taking back a bit of control. Let's get started. Tonight's first speaker is Dr. Razina Patel. She's a fertility specialist at Sandton Fertility Clinic. We'll be talking to you tonight about PCOS. Over to you, Razina.
Thank you, Saskia. Good evening, everyone. I'm just getting my screen together. Good evening. I am Dr. Razina Patel. I'm from Sandton Fertility Clinic in Johannesburg. I'm here to talk to you about polycystic ovarian syndrome, which is a hormonal imbalance with a fancy name, I'd like to say. I think we all blame hormones for lots of things, whether it's weight, whether it's libido, whether it's acne, whether it's irregular menses and infertility. And one mustn't forget that polycystic ovarian syndrome is just a fancy name for a hormonal imbalance. It's often a loaded diagnosis. People are very upset when you tell them they have it. They liken it to cyst on the ovary that needs surgical treatment. They blame the polycystic ovary for pain, which is not real. So it is not something simple according to the public, and yet to us, as much as it is complex, the fact that it is so common and so often undiagnosed with good outcome, that when we do diagnose polycystic ovarian syndrome, we are confident and calm because we know the disease and we know what can be done and should be done and is being done to help people who have it. I often say, make friends with polycystic ovarian syndrome, don't make it your enemy, and we can control it. and we can not cure it, but you have a hand to play in making it the best that it can be, and we will help you along. So if I talk about it being a hormonal imbalance, and I want to tell you where the hormonal imbalance starts from, I will demonstrate and illustrate to you the normal menstrual cycle. So the picture on the screen illustrates the hypothalamus, which is in the brain, and the pituitary gland, which is also just behind the nose in the brain and face area. They are both responsible for what we call releasing hormones, because they are the initiation of the cascade of hormones that ends up making the ovary produce the egg. So the hypothalamus in a normal cycle will release GnRH, fancy name for the fuel that goes to the pituitary gland, and the pituitary gland responds by producing FSH and LH. Both of those enter into the circulation and go to the ovary, where they do the following. The FSH will address the granulosa cells in the follicle. If you look at that circle floating off to the right-hand side, it starts off in the ovary as a little circle with not much fluid in it, which is why it doesn't have any white in it. It's on the extreme left of that ovary. And as the arrows point, it goes from being a tiny follicle, collecting fluid within it, at the same time maturing the egg, which then escapes from the ovary as an ovulated oocyte. The FSH is stimulating the granulosa cells in that ovary, in that follicle, to nourish the egg, and the LH is stimulating the theca cells to produce male hormone. So the ovary then is responding to the stimulation from the brain, making an egg ready, facilitating ovulation, and releasing estrogen, progesterone, male hormones into the circulation, and finishing the cascade. The hormonal music generated by the GnRH, the FSH, the LH, the estrogen, progesterone, and androgens are what drive the regular menstrual cycle. If we talk about what is so different with polycystic ovarian syndrome, we think the condition starts in the brain. And the GnRH that is released by the hypothalamus is no longer in a rhythmical rhythm through the day. It is pushed through in a very rapid fashion and results in abnormal stimulation of the pituitary gland. And the pituitary gland responds by changing how much LH it produces and how much FSH it produces. So the LH increases. It then stimulates the theca cells too much, and they produce too much male hormone. The FSH, which is supposed to make the egg grow, drops, and it doesn't facilitate the growth of the egg. So the whole system doesn't end up causing ovulation, and that is why in a PCO ovary, ovulation is inhibited. It is inhibited because there's too much male hormone in that ovary, and there's not enough stimulation of the egg by the FSH because it has dropped and the LH level has risen. When we talk about how the polycystic ovary looks, then it is understandable that the small follicles in that ovary that wanted to become the dominant follicle and be pushed out of the ovary cannot get to the mature stage, and so they end up being the small, unruptured, immature follicles, and they accumulate in the ovary, giving the ovary this appearance. If you look at the normal ovary on the left-hand side, the follicle eventually is mature, but has come through many different stages: the primordial follicle, the primary follicle, secondary follicle, then only the mature follicle. But if you look at the picture on the right-hand side, the polycystic ovary doesn't get to form a mature follicle, and they stay almost stuck in second gear. And so those cysts that we see on a polycystic ovary are not really cysts. They are follicles that didn't complete the journey because they were not given the right instructions. So in actual fact, when it was first described, I beg your pardon, when it was first described as polycystic ovaries, it was because the people that defined it used the wrong name for the follicles and called them cysts. So in actual fact, this is polyfollicular syndrome. And why that is important, I think, is because if we find cyst in your brain, it would be completely abnormal. But if we find cyst in an ovary, which is really, a cyst is really a fluid-filled space. If you find fluid-filled spaces in the ovary that contain eggs and would have loved to make it to the mature follicle, then that was just an ovary working right, but didn't get to complete the task. So polyfollicular ovarian syndrome feels normal and and incomplete, but not abnormal. So the cysts that people need to take to surgery, the cysts that cause pain, are not these. This is a normal occurrence in the ovary that just doesn't complete the journey. If we go from here, so what do we know about polycystic ovarian syndrome? Now that I've said that it is quite common. So it affects, on the second point now, sorry, it affects about 6 to 10% of women between the ages of 15 and 44, effectively 1 in 10 women, which is very common. And it is the most common hormonal disorder in women of reproductive age. It is also the main reason why people see us in fertility clinics, and the main reason for anovulatory infertility. That means women who don't ovulate and therefore don't fall pregnant. So there are many women who might have the condition and are just never investigated because they are lucky enough to be ovulating at the same time. Some women with PCO do ovulate. And so we've never really investigated them or put them under the microscope and never given them the label. So there are ovulatory cycles. They may just not happen every month. And in order to have a good chance of falling pregnant, we need to ovulate every month, giving us a chance per month of about 20% of falling pregnant. So every woman then trying to fall pregnant gives herself 6 to 8 months, because then the cumulative pregnancy rate results in a good percentage of pregnancies after 6 months. 80% of people will be pregnant after 6 months, provided that you're ovulating every month. So if you are a woman with polycystic ovarian syndrome and most months you don't ovulate, then you don't stand the chance of being pregnant every month of 20%. And so it takes you longer, but it's not a never situation. As I've said to you, the hormonal imbalance results in the lack of maturation of the follicle in the egg, and therefore the immature follicles build up in the ovary, and it gives it a honeycomb appearance. So what do we know about what causes polycystic ovarian syndrome? We've explained what happens and what the GnRH does and what the FSH and LH does, but where does it come from? Why do some people get it? It's not fully understood, but there is a genetic component definitely. And if you have polycystic ovarian syndrome, your sisters and daughters have a 50% chance of developing it too. It also seems that some ethnic groups are more at risk than others. Environmental influences, it does seem that lifestyle plays a big part. So health, diet, exercise, and lifestyle factors combined with genetic and familial factors push people into that stage where their metabolism just doesn't recover. And the more overweight a person is, the more acne you have, the more irregular your cycles, the more wild the polycystic ovarian syndrome is at that point in time. And there can be times where it subsides and it settles, mostly related to when people start being good about diet and exercise and losing weight. So it may often happen that a person, like I say, with PCO doesn't need help and falls pregnant. And it sometimes happens that somebody who needed help and came to the clinic and was treated falls pregnant, and after her delivery decides, I will wait to go back to the clinic to have my next treatment, but for now I don't need contraception. And before you know it, she is pregnant, because the body can facilitate an ovulation from time to time based on how you are treating it with other factors that can push it into overdrive in a sense. It is also related to metabolic syndrome, which is then the condition in families where people have high blood pressure, diabetes, obesity, high cholesterol and heart attacks. So you're almost destined to have it if you do have a family that is burdened by these conditions. I might say in the Indian community it is like that. In the Afrikaans community, I know there's lots of high cholesterol and heart attacks, but sometimes we're sitting ducks and we are running a race with our genetics, and for the most part we are winning, and at some points genetics takes over. And I often think that young women who are alerted, or even women in their reproductive age who are alerted to their condition when they're younger, are actually lucky, because they might well change their lifestyle and prevent themselves getting into the situation that their elders have already gotten into. And by the time a woman comes to visit us in the fertility clinic, she is so desperate to do whatever it takes to make the cycle work that you might well get a good commitment to a healthy lifestyle and weight loss in that situation. So in a way, it is a way to embrace and deal with what you have on your plate already, and what you can't escape but you can control. And it does seem that if you work on the rhythm of your hormones when you are younger, that you don't trap yourself further and further into the bad, the worst of the condition. Because if you treat your body badly, you get trapped in the hormonal imbalance and the complexity of it, and to pull yourself out of it is very difficult. Whereas if you stay above board and just keep it tamed and in check, you probably win the war in the long run, I guess. So the thing about insulin and androgens then is what we're saying is people who have polycystic ovarian syndrome are often in what we call insulin resistant. And insulin resistance also is associated with excess weight. So in a way, people who have polycystic ovarian syndrome and are overweight are that way for two reasons. One is that the polycystic ovary is being burdened and chained by the elevated levels of insulin as such. And because insulin then leads to fat storage, and fat storage is weight gain, and weight gain then feeds back into insulin resistance, they often feel trapped. We have people who tell us, I exercise very well, I eat healthy, I just can't shift this weight. And it is a question of the insulin being so high that it doesn't allow for any good effort that you are making to make a change in the weight. And we often see people who are frustrated and who are losing momentum because they don't see the rewards of their efforts, and before long they give up on the diet and the exercise. If we look back at the insulin resistant and the high insulin in this chart, it actually also drives testosterone production, because it also influences in the ovary the theca cells, and the theca cells then also produce excess testosterone. And the testosterone is what we call androgens, it's male hormone, and the androgenic effects in the body are the acne, and there are hirsutism, which is excess hair in abnormal male distribution patterns, so upper lip, arms, chest, around the nipple. And besides the acne and the hirsutism, there's irregular periods, and irregular periods mean infertility. I will explain that a little later, but in essence, if we're having irregular periods, we are not ovulating. And if we're not ovulating, the eggs are not in the tube, and so we cannot find them to fertilize them. So that ends up being infertility. Again, about the insulin and the LH, the insulin resistance is a key factor in PCO for many women, and the insulin will lead, the elevated insulin and the elevated LH lead to too much male hormone, and because of the male hormone being elevated, the follicle is arrested and cannot ovulate. From here, what are the noticeable effects of polycystic ovarian syndrome? So some things we see and some things we don't see, but people often come in complaining of unpredictable and irregular menses. They might complain about it from the time they started menstruating, or they might say that over time they put on weight, the acne got worse, the hair growth got worse, and then the menstrual cycle just went out of sync. The acne also flares up when the PCO is at its worst. And we also then find that there is also the coarse and excessive hair growth in the unwanted areas, as I said. Some people actually experience hair loss as well, because male pattern baldness is related to elevated levels of male hormones. So we get too much hair in places we don't want, and then hair loss in places we want to have hair. I've said to you that we have difficulty with losing weight, but there's two groups of PCO patients. Some are overweight and some are skinny. The overweight patients may also, besides the risk of diabetes and being pre-diabetic, they may also go into more serious consequences like sleep apnea, which is a condition where people don't breathe well when they are asleep, and it's related to obesity. And we need to emphasize here that some women are slender, because there was a time when we thought all women with PCO had to be overweight, had to have excess hair, problems with hair growth, had to have acne, and were irregular. Now we do find that some people are actually ovulate. Some people actually ovulate and they are slender, and they may not have too much problems with acne and hair growth. As I said, infertility is due to the lack of ovulation. The psychological distress that comes about with PCO is related to the infertility. It's related to the body image issues. It's related to the discomfort with whatever weight issues they've had, because from that also comes a whole impact of different physical, emotional, and psychological problems. I think besides the psychological issues that relate to what we can understand from PCOS and the physical challenges a person might have and the infertility, I have recently heard from a colleague that some mood disorders like bipolar mood disorder also are associated with PCOS, because I think it goes deeper than just cause and consequence. It's not just a psychological distress of consequence. It is related to chemically something changes as well. The condition called acanthosis nigricans is also a thick, dark skin developing around the neck, the underarms, and the groin. Often people who are overweight also have folds of skin that get itchy, and maybe the continuous scratching can also lead to those changes in the skin. Hidden symptoms of the PCOS is that diabetes and pre-diabetes is also obviously a problem because of the weight issue. And obviously, like we said, it is in the genetic components. And so we're never really escaping it. This is the early form of what is to come. So they say as much as 50% of women with PCOS will develop diabetes or will be pre-diabetic by the age of 50. Insulin resistance then is not diabetes. What it relates to is, in order to keep your glucose levels normal, your body produces insulin, which then is the guard. It makes sure that in the circulation, the level of glucose never goes higher than a certain level, because your body cannot tolerate high levels of glucose in the bloodstream. So what the body does then, it produces insulin, which then pushes glucose into the cells and it doesn't leave it in the bloodstream, because in the cells, it can, I'm so sorry, I'm just getting distracted. In the cells, it will be hidden and won't be diabetic. Oh, okay. Okay, all right. All right, so thank you very much. I've lost my train of thought there. It probably needs a bit of discussion, the insulin resistance. I've listed what we had to worry about. The one thing I want to talk about right at the end is the risk of cancer, because if you're not ovulating and you're not shedding the lining every month, then the lining of the uterus can get thicker, and in getting thicker, it will become precancerous if we don't allow and facilitate regular withdrawal bleeds. Also, just quickly to say that a woman diagnosed with PCOS have the risk of infertility, anxiety, depression. They even say drug use. I suppose they all go together. I'll move through that. I'm so sorry, I'm moving fast just because some of what I'm saying is a repeat, and also I think I've been talking too much. Okay, the effects on PCOS in pregnancy, once you manage to fall pregnant, Early miscarriage is a problem. Gestational diabetes is also a problem. Premature delivery and small for gestational age babies. High blood pressure of pregnancy also. And we do find that sometimes babies can be sickly and it can result in what we call perinatal mortality. I must say that as much as these are statistics, I would say that when you are pregnant after a fertility cycle and you have PCOS, I think we look out for, guard against, work towards treating or fixing the problems that you have here, but by no means are we saying that we're still in trouble and we don't have a good outcome. Mostly we have a good outcome. The treatment of PCOS symptoms, a few things. Ovulation induction for fertility is important. The oral contraceptive pill can be used to regulate the menses and the hair growth and the acne. And unwanted hair, you can use finasteride. Metformin is glucophage. It helps to lower insulin levels and also helps in ovulation. Exercising and eating healthy are a very important thing to do. We've talked about good healthy behavior, which is the last point, and the psychological symptoms that we need to work with. So just on this slide, probably the most important thing is to have a low glycemic index low glycemic diet. I'll stress also that do low cholesterol as well, because oftentimes cholesterol is high in patients with PCOS as well. So while you are there, do both low GI and low fat. And always remember to have enough exercise and enough fluid intake, enough sleep. All of those are important. Just a few things of what can work for you. Low GI, obviously, and then the antioxidants that come in berries and leafy green vegetables and olive oil and fatty fish for the omegas and some of the vegetables on the other side. The use of metformin, I'll quickly skim on that quickly. The metformin is an insulin sensitizer. It facilitates the drop in insulin levels. It also facilitates the weight loss in people who are eating healthy and exercising. But people hesitate to take metformin. They might well have had a bad experience with it because it can make you feel nauseous, it can make you tired, it gives some people diarrhea. And also it is quite stigmatized because people think of it as a drug for diabetics, and granny might be taking it. And so when we tell you to take it, you think, but I don't have diabetes, do I? Or when you get to a pharmacist, the pharmacist questions you about whether you have diabetes. So you'd be using it for insulin resistance, not for diabetes, and they're not one and the same. It's used by doctors anyway, although the evidence is not always in keeping with definite benefit when we use it in cycles, but we do use it because we do find, from our personal experience, we get good results. And it's also important to keep the patients motivated to lose weight because, like I said, insulin traps you and doesn't allow you exercise and healthy eating to help you, and metformin will help you to lose the weight. I'll quickly go to this slide because what I wanted to show with this, and that's a simple idea of why we do ovulation induction in people with PCO, because the top part is a normal cycle, and on day 1 of the cycle, which is when the menses starts, your body begins to produce a hormonal music. And so my up and down on that, the serrated pattern, is the hormonal music that your body is supposed to produce, making the follicle go from being a small follicle to a mature follicle and ovulating. Beyond ovulation, the body will wait 14 days, and after 14 days, we'll have another period. That cycle is intact because everything is in place. The hormonal music is right, the follicle matures, ovulation occurs, the 14 days are counted down, and then comes your next period. Look at the PCOS cycle underneath that. Day 1, when you bleed, look at the hormonal music that your body is producing. So the hormonal music doesn't give you the serrated pattern. No egg is being matured, no ovulation occurs, no 14 days are counted down, and you pass the day of your period, which is why people don't have a predictable pattern. I'll leave that as it is, and I'll talk quickly about something called ovarian drilling, which we sometimes use in polycystic ovarian syndrome. And the reason why is that in this ovary, there are multiple follicles. They are all loaded with male hormone. The male hormone stops the ovary from ovulating. And so we sometimes want to empty or decrease the androgen load in that ovary. How do we decrease the androgen load? We want some of those follicles to shed their male hormone. In the past, we used to do what we call a wedge resection of the ovary. And that meant that we took almost like a slice of cake from the ovary, removing a whole lot of follicles that were full of androgens. But we also did, in that way, remove a whole lot of small eggs that would have been of benefit to us. So we don't do wedge resection anymore. We destroy too many good follicles. We now do what we call ovarian drilling. If we get to theater, we don't always do it as a routine either. But what happens if we get to theater and do a lap scope, we will take a heated needle and we will push it through the ovary, and we will go through some of the follicles and release some of the male hormone. It makes the ovary less stubborn. It makes the ovary have a chance of ovulating on its own. And it certainly helps that when we give you medication to help that ovary to ovulate, that the ovary listens to our instruction. I have to finish. We will wait for questions. Thank you for your attention.
Thank you, Dr. Patel. We really appreciate you taking your time and sharing your knowledge about PCOS with us. And there are a few questions for you, which we'll get to at the end. Okay, our next speaker, Walter, are you ready? Walter Mbatha is the CEO of 360 Biomedicine. And he's going to be talking to you tonight about what they have planned for Women's Month next month. Over to you, Walter.
Good evening, everyone. My apologies, I was having a bit of a challenge with technology.
All right.
All right. Firstly, let me just start by thanking everyone for making the time to actually come through to listen to us, and also thanking IFAASA for this opportunity that they've granted 360 Biomedicine to be a partner into such a great initiative. All right, what I'll do, I'll take you through the who 360 Biomedicine is. Let me see if I can manage to project my presentation. I hope everyone can see my screen.
Perfect.
All right. So just basically, just to take you through to, in summary, as to say who 360 Biomedicine is. We are a level 1 BE Black-owned business that provides biomedical scientific services. Our main key focus is on natural extract and organic ingredient, and we committed in providing world-class innovative healthcare solution to the global market. And we have partnered with other industry leaders, both locally and globally. Just to give you a brief overview as to say who we are, 360 Biomedicine is a subsidiary of 360 Global Solution Group. We formerly known as 360 Financial Services Group, a leading diversified business with an interest in funeral and financial and healthcare and scientific and technology services, right? And the group merged from the Doves Group, which grew into a financial services and has ventured into a biotechnology, which gave birth to 360 Biomedicine. Okay. We are a young, ambitious company. The business was actually officially registered in 2019, and it has already has few products in the market, and we have even far more new products under in the pipeline. They're still under development. 360 Biomedicine also acquired a business in KZN, Troy Pharmaceutical, which is now called 360 Herbal Health, which it oversees the manufacturing and commercialization of herbal-based indigenous remedy-based products that we manufacturing and supplying to the market. In addition to that, we actually collaborate with the CSIR, where we conduct our research and technology innovation in making sure that the products that we develop are of the highest quality and they are backed up by scientific research. And one of our key affiliates and one of the company that I'm also responsible for is the 360 Biopharmaceutical, which actually focus on innovative allopathic medicine, which is targeted at providing solution to South African healthcare. One of our key focus is also including infectious disease. 360 Biomedicine, as I've mentioned before, that our key focus is mainly on natural and organic science to make complementary and alternative medicine. And also we have a business line extension that oversees the production based of cannabis-based products, which focus on dermatology and also into pain management as well. One of the reason why we felt the need to actually partner with IFAASA was that our key major products that we have available and the investment that we have done through the key interest in women's health, where we saw an opportunity of unmet medical needs within that space, and of course and trying to see what is the best way of providing solution which are more natural and moving away from other allopathic form of treatment, so that and when we mention natural or organic, I would like to also emphasize the fact that our treatments are mainly scientific based as well, where we focus in treatment of infertility in women who suffer a lot on polycystic ovarian syndrome, as Dr. Patel has just gone through the brief description, giving women products that contain natural ingredient for common problems such as menstrual pain, heavy menstrual bleeding, premenstrual syndrome, and also menopause. Yeah, that is a brief summary as to who we are as a business. And for more product info, I think I would actually refer people to go through to our website, which is www.360biomedicine.co.za. They can also find us on our social media platform, on Facebook, Instagram, and Twitter. Our handle is @SalomeRange. They can also visit our Facebook page for 360 Biomedicine page. Thank you.
Thank you, Walter. And we also want everybody to know about the initiative you're doing for next month. It's Women's Month, and you guys are doing a few initiatives bringing attention to women's health. So they can follow you to find out more details for that. Okay, yes, our final speaker for tonight, thank you, Walter. The final speaker for tonight before our Q&A session is Dr. Sulaiman Heylen. Dr. Heylen is a specialist in reproductive surgery and is the chairman of Cape Fertility Clinic, as well as the president of SASRE. He will be tackling the topic of endometriosis. Over to you, Dr. Heylen.
Thank you, Saskia, for this very kind introduction. And I would like to congratulate IFAASA for this wonderful initiative. And it's a privilege to be part of this. Can you please let me share my screen, Saskia?
There you go.
Thank you very much.
Apologies.
No problem. Is it on?
Yes, perfect.
Perfect. So everybody always asks me, the first question is, Doctor, where are you from? Because of my funny accent, I'm from Belgium in Leuven. I qualified there, did my undergraduate and my postgraduate there. But I'm happily married to a South African, and that's why I'm now very happily in South Africa. So the topic of today is endometriosis. And endometriosis is a big problem. And I call it always one of my terrible four. So Dr. Patel spoke about polycystic ovaries. We have fibroids of uterus. We've got tubal disease. And then we've got, last but not least, we have got endometriosis. So what is actually endometriosis? Endometriosis is a benign condition and in which the lining of uterus, which is the inside of uterus, is growing on the outside of uterus. So basically, what is endometriosis? endometriosis is lying on the wrong place. And there are different classifications of the disease. And that's why we hear about 4 stages, 1, 2, 3, and 4, from minimal to severe. So that's how it looks like under the microscope. And these are these spots of endometriosis, or these growths of endometriosis that are growing on the outside of the uterus. So it's very important to understand that endometriosis is not a disease of the uterus, but from outside uterus, usually around the ovaries and the fallopian tubes and the back of the uterus. And it is very common, and similar to Dr. Patel's polycystic ovaries, it can happen in 5 to 10% of the female population. And it is mainly a disease of young women, women in their best years, in their reproductive years. And what we see more recently, we also see younger and younger. We see a lot of teenagers with endometriosis. And endometriosis can cause symptoms, and the symptoms are painful periods and pelvic pain. So 50% of women with severe painful periods do have endometriosis. And endometriosis can be responsible up to 75% of all cases of chronic pelvic pain. And another very common problem is obviously infertility. So 1 woman out of 10 can be affected by endometriosis. So if you have a class of 20 or 30, 2 or 3 of them will have endometriosis. So it's a very common problem. And that's how it can look like by the laparoscopy. We see all these growths, or it can sometimes also be what we call an endometrioma. And what an endometrioma is also called a chocolate cyst. It's a growth inside the ovary of endometriosis. So what are the symptoms? The symptoms are painful periods. And painful periods are common, and a lot of women think it's normal. But if you really need pain medication, if you say, I've got every month 2 or 3 days pain, and I really need to take painkillers, that is not normal pain. Normal pain is where you say, okay, you can take it, maybe you take 2 Panados and it's fine. That can be normal, but if it's more than that, that could be an indication that there is something wrong. So pain can also be in between periods, and then we speak about chronic pelvic pain. And very often the pain is not so much, but over the years it gets more and more and more. Then it can also be pain when passing urine or stool, or also quite common, we can have pain during sexual intercourse. And again, we look at the pain scale, going from green to red, or from 0 to 10. And we can ask women, how bad would you describe this pain? And we see that a lot of women with endometriosis describe the pain as 7, 8, 9, or even 10, or very common, even 11, they say, because the pain is so bad for a few days every month, or many days every month. But endometriosis can also interfere with fertility, because it can cause scar tissue around the fallopian tubes. It can interfere with your ovulation, and therefore it can interfere with fertility. So the symptoms are pain and infertility. And very often women with endometriosis can also have other symptoms like fatigue, depression, gastrointestinal problems, spastic colon, eating problems. But it is also important to understand that endometriosis can also give no symptoms. So it's not because there is endometriosis that there must be symptoms. A lot of women have endometriosis without symptoms. And it has got a lot of consequences because it affects the women in their best years, in their most reproductive years. So it can lead to being absent from school, from work, having a long socio-economic cost. So it can have a cost for the society, but also it has got a big effect on the woman herself, because on her quality of life. Women must take off from school, from university, and therefore they can't do their studies properly, or they have to take off from work, and it can have also an effect on the fertility, can therefore also lead to problems with their self-esteem. Another problem with endometriosis is that there is very often a delay in diagnosis. From the first time that women go to a doctor with complaints about pelvic pain, up to the moment of the diagnosis is an average delay of 7 years. And that's not good enough. We as doctors need to do better. So how can we diagnose? So we have to have a high suspicion because of what the patients tell us. So if somebody comes in the office and gives us a typical history from, I have got period pain and it's getting worse and worse every month, we must think this is probably endometriosis. Then recently we have got very good ultrasound machines, and now with ultrasound, in the majority of the cases, we can pick up endometriosis. The ultimate diagnosis is done by laparoscopy, but it is a pretty invasive thing, and we try to avoid it if it's not necessary, and therefore we can sometimes also assume the diagnosis of endometriosis and carry on with treatment. A laparoscopy is a minimal invasive surgery. So we always like the aspect of it being minimal invasive, but it is still surgery. That means it is a procedure in the hospital under general anesthetic. The recovery is quite fast, and very often the women can go home the same day unless it's severe disease. And then we can not only see the endometriosis, but we can also treat the endometriosis. And the main treatment, the golden standard, is to do an excision, to remove the endometriosis and excise it, and not only to burn it. So there are different stages of endometriosis. This is a bit of a complex slide, but it is important to know that there are 4 stages of endometriosis: minimal, mild, moderate, and severe. And there is not always an association between the symptoms and the severity of the disease. I give an example. A woman with minimal or mild endometriosis can have very severe pain, or a woman with severe endometriosis can maybe have no pain at all. So there's not always a correlation between the classification and the symptoms. And this classification is actually a laparoscopic staging. That means it's the doctor during the laparoscopy who classifies the disease between stage 1 and stage 4. So let's speak a little bit about what can we do about endometriosis. We can give medical management. Medical management, it's hormonal treatment. So every treatment for endometriosis, where we're not just only giving painkillers, is hormonal medication. A very common treatment that we do is birth control pills. Birth control pills have been shown that they reduce menstrual pain by more than 50%, and it can help a lot of women with menstrual pain with endometriosis. Other options are the Mirena. What is the Mirena? A Mirena is a loop that is inserted inside the uterus and that contains progesterone, and that will reduce the amount of bleeding and will also reduce the amount of pelvic pain and painful periods. A drug which is specifically designed for the treatment of endometriosis is called Visan. Visan is a single tablet that must be taken every day. It can sometimes cause a little bit of side effects the first few months, but after a few months, most women are getting quite used to it, and it is like a little miracle for the treatment of endometriosis because it can take the pain completely away. There are stronger options like Zoladex. Zoladex is a medication that knocks the period out, so a woman will become in what we call an artificial menopause. It is very good for treatment of pain. However, the side effects are quite severe, and therefore it's usually only used as last resort or in reserve. The injectable contraceptives are not used that much anymore because women tend to gain weight with it. So that's why we try to avoid the injectable contraceptives and go for other medication. And then the other thing is can be done is surgery. So surgery should be done by a specialist in endometriosis. And it is important to understand that not every doctor, not every surgeon, and not every gynecologist is specialized in excision surgery of endometriosis. So it's best to go to somebody who specializes in that because the first surgery is the best surgery. A lot of women have repeat surgery after repeat surgery, and every surgery becomes a little bit more difficult and a little bit less successful. Also, the timing of surgery is very important, and it's not always necessary to do surgery if there is pain, but we can wait until a woman is trying to conceive. And it must be, obviously, we must look at what are the complaints of the patients. So it's important to understand that pain is not in your head. And a lot of women feel that menstrual pain or chronic pain is normal, and it's not. And many doctors tell the patient there is nothing wrong, but it is important that we have a good look, a careful examination, and that we exclude endometriosis, because it has a big effect on the life and it can lead to other symptoms like anxiety and depressions. And we do have many problems with the treatment of endometriosis, because must we treat the disease, must we treat endometriosis, or must we treat the problem, must we treat the pain or the fertility? And are we always acting in the best interest of the patient? And I have personally identified 3 problems with the treatment of endometriosis: problem 1, problem 2, and problem 3. So problem 1 is a private fertility specialist. He's quite rich. You can see he's wearing a fancy suit and he's running a very successful IVF unit. So if you visit him with a fertility issue and you've got endometriosis, you're quite likely to end up with having IVF. Problem number 2 is an endoscopic surgeon. He has done many courses and he considers himself as a specialist in laparoscopy. If you go to him and you have endometriosis, you end up very likely of having a laparoscopy. Problem number 3 is a general obstetrician and gynecologist who is very busy, who is a very nice guy and is very much liked by his patients, but he doesn't have time to do a lot of long surgery, but he's very good in endocrinology. So if you come to him, you'll probably end up having medical treatment for your endometriosis. And endometriosis is a holistic approach, is a combination of medical treatment, surgical treatment, and assisted reproduction. And you must always try to see what is the best interest of your patient. And we must not treat the treatment based on the classification or the severity of the treatment. That's not the issue. We must listen to what are the symptoms of the patient. Is the patient complaining for infertility or for pain, or does the patient prefers medical or surgical treatment? So our job is to explain our patients what are the options and to listen very carefully to what they are saying. And it's not so difficult because there are guidelines. There are guidelines by international societies. They're all over here, but there are also guidelines by us, the South African Society of Reproductive Medicine and Gynecology, which is basically the South African Fertility Society, and you can find them on this link on our website. So mistakes of treatment are common, and therefore there can be a delayed diagnosis, and surgery can be offered, and medical treatment can be offered, and IVF can be offered, or surgery can sometimes be too aggressive. And it is important to understand that endometriosis must not be treated. A patient must be treated. Endometriosis is a benign disease. So we listen to what the problem is and we try to identify the problem and to help with the problem. We try to help with the pain, or we try to help with the fertility. And the endometriosis treatment does not depend on the severity of the disease, but it depends on the problem. A few small examples. A patient, for instance, 25 years old, was on birth control pills, was not planning to conceive, was diagnosed with an endometriosis cyst and was recommended to do surgery. It's not necessary to do surgery in a case like that because she had no symptoms at all, and she can very well wait with the surgery until she would like to have a baby. Maybe she will even conceive spontaneously and she will never need surgery at all. That was too much surgery, or it can be too little surgery, or it can be sometimes people that have too many aggressive surgeries. It's a very common thing that we see women who have had endometriosis have multiple surgeries. So we see sometimes women that have so many surgeries that the ovaries are virtually removed and that they have no eggs anymore. Or we have people that have done incomplete surgery. They do a laparoscopy for endometriosis. The endometriosis is not completely excised. Very often deep endometriosis or rectovaginal endometriosis is missed. It's not removed and the pain is still there. Or people go for surgery, they have multiple surgeries, they have long-standing problems of infertility, but IVF is never discussed with them, and they are offered medical treatment which is not successful. So the treatment of endometriosis is a combination of medical treatment, surgical treatment, and assisted reproduction. And we as doctors, we are not always listening to our patients. We must listen to what they're saying and trying to help them as good as possible. And It's important also that it can lead to depression and anxiety and can have many effects on women. The anxiety can be irritability, tension problems, sleeping problems, a general feeling of not feeling well. Depression can lead to weight gain, weight loss, insomnia, lack of energy, inability to concentrate, and many other problems. And these other associated problems with endometriosis are as important as the infertility and pain, and we must also listen to our patients about that. So the treatment options are different for pain and for infertility. We have got, for pain, we can give medical treatment, the hormonal treatment that we discussed. We can give painkillers or we can do surgery. For infertility, we can give hormonal treatment, we can do surgery, or we can do assisted reproduction. And very often a combination treatment is necessary. So we can say that medical treatment is never effective for infertility. So women with infertility should not be prescribed things like Razina. Oral contraceptive pills and Mirena are very good first-line treatments for pelvic pain and endometriosis, and surgery is in most cases not the first-line treatment for pain. Razina is very effective and can be used as a long-term treatment option in the treatment for pelvic pain related to endometriosis for many years. We have seen many patients that have multiple operations for endometriosis. They've got chronic pain. They go on Razina for years. They've got no pain anymore, nothing. But it's always important to listen to your patient preferences. Consider the cost, the side effects, and the availability also of the treatment. Surgery is the first-line approach for all stages of endometriosis if there is infertility. So if there is infertility and endometriosis, surgery is always a good option. And then we have got as plan B, the assisted reproduction like IVF and intrauterine insemination. So it's different from pain and infertility. For pain, medical treatment is first, and if that fails, we go to surgery. For infertility, surgery comes first, and if that does not work, then we can go to IVF or IUI. Thank you very much.
Thank you, Dr. Heylen. I really do appreciate you giving your time tonight to impart your knowledge, and I know that a lot of people that benefited from that presentation. We do have quite a few questions. So we are going to run a little bit over time tonight, but I think we should answer a few. And then if we don't get to the questions, if we don't get to your question that you've posted, please can you email the question to me? It's Saskia, Saskia, at IFAASA, IFAASA.co.za. And then I'll send it on to the doctor and we'll get the answers over the next few days. So let's start off with Dr. Patel. Are you there?
Thank you, I'm here.
You are. Okay, let's see. Would a woman with PCOS be unsuitable to donate eggs for surrogacy on the basis that ovulation is unreliable?
So if you were to be a donor for someone, we would stimulate you to give us more than one egg, because that's how you qualify to be a donor, because we want a number of eggs for your recipient. And so when we take over control of your ovaries, we will make them ovulate. So no, you're a very suitable donor and an ideal donor.
Perfect. Dr. Patel, could change in cycle length be a sign of PCOS? So cycle is between 22 and 29 days, changing each cycle.
So the cycle is only between 22 and 29 days, that maximum 29?
Yeah.
So we would have to do more. Classically, they must, so you can be a ovulatory PCO patient. It would need more investigation. We'd have to look at the ovarian hormones, and we'll look at the appearance of the ovary peak. We need more features. We need some features of male dominance, male hormone, and we need some features on the skin and possibly even blood results. So it could be, but we need more.
Thank you. Dr. Heylen, can a teenager be diagnosed with endometriosis?
Oh, yes. We see more and more teenagers with endometriosis. So very often we see young women, 14, 15, 16, 17, 18 years old. And it's not always possible to do all the examinations on them because a vaginal scan is not always possible to do, but we carefully listening to them, we very often can make a diagnosis of endometriosis and give them appropriate treatment. And I think it's very important for these young women to also to treat them properly because it can have a very big effect on their lives, because they can miss school every day, every month, a few days. So it is very important that we listen to them and treat them properly. Yes.
Thank you. Dr. Patel, how long does the effects or the benefits of ovarian drilling last?
So once you come out of surgery, in the next three to 6 months, we try to assist with making that intervention effective. So mostly we would have to decide whether we're doing anything to stimulate you at the same time, or we're giving you 3 months to try, and then the next 3 months we jump in with some medication. So I don't think longer than 6 months. In that 6 months we get going.
Thank you. Dr. Heylen, can endometriosis disappear naturally?
Yes, it does disappear naturally after menopause. Huh? So that's the nice thing about endometriosis. So after menopause, it in the majority of the cases goes away. But as long as there is female hormone, as long as there is estrogen, there will be endometriosis. So it's a disease of the reproductive years. So otherwise, it's not likely that endometriosis will disappear, although we see sometimes women that have had very bad endometriosis that later on in life, when they're in their 40s, they've got no symptoms or very mild symptoms.
Okay. Dr. Heylen, I'm 31. Doctor picked up possibly stage 3. I have no symptoms. However, I'm struggling to conceive. And my doctor recommends a laparoscopy, then IVF. What is your opinion on this?
The right thing to do. So if you have got endometriosis and there is infertility, the best thing is to do a laparoscopy by somebody is very good at treatment of endometriosis, and then try to conceive spontaneously. If no spontaneous conception occurs and dependent on other factors, also like male factor, female age, tubal factor, but then we normally wait 9 months to 12 months after the laparoscopy. If no conception occurs, we do IVF. So it's definitely good advice.
Okay. Thank you. Dr. Patel, can you have PCOS while you still get your menses every month?
Yes, some people do ovulate and have regular menses.
Okay. Let's see. Dr. Heylen, my RE picked up endometriosis on internal scan. My CA125 blood test came back normal. What does this mean, and is a laparoscopy still recommended before IVF?
Short answer, no. Long answer, maybe. So we can do IVF on women with endometriosis without any problems. So if a woman has got endometriosis and there is a cyst on the ovaries, or is there rectovaginal endometriosis, the endometriosis must not be removed before we do IVF. If there is a cyst, we can just go around with our needle and aspirate the eggs out. And if we do surgery before we are going to do IVF, very often we can what we call reduce the ovarian reserve. That means we're cutting away eggs. And therefore, there can be less eggs for the IVF, and the laparoscopy can maybe even reduce the chance of success. However, there can be sometimes exceptions. If there is an anatomical problem, or if we think that from a safety point of view, it's best to remove the endometriosis, then a laparoscopy can be indicated. But as a general rule, I would say, if there is a good, say I gave an example, say if there is a couple that needs to have IVF because the husband has got a problem, but she also has got endometriosis, then it's not necessary to remove the endometriosis before we're going to do IVF. So a laparoscopy is not always necessary before we do IVF, and it is definitely possible to do IVF if there is endometriosis in place.
Thank you. And then let's do one last one. Dr. Heylen, I'll be treated with Vizan. Does this mean that adenomyosis, is that how you said, won't return and one can fall pregnant naturally, if that's possible?
Yeah. So adenomyosis is something different. So adenomyosis is the cousin of endometriosis. So we spoke about endometriosis. It means that lining is growing on the outside of the uterus. What is adenomyosis? It's the lining is growing in the muscle of the uterus. So it's lining, abnormal lining in the muscle of the uterus. So very often it goes together. A lot of women with endometriosis also have adenomyosis. And we do give treatment with Visan for women with adenomyosis too. However, there is not too much evidence on if it's beneficial for conceiving, but it seems to be a good option. And if a woman with adenomyosis is on Visan, it will definitely reduce the amount of pain. So in that case, it will be beneficial. Will it help her to conceive later on spontaneously? Maybe, but maybe also not.
Thank you. And then let's just take one last one. Dr. Heylen, can stem cell therapy help with egg quality with stage 4 endometriosis?
Not yet, no. We are not there yet. Good question, short answer, yes. Definitely not.
Perfect. Okay, if we didn't get to your question tonight, please email them to me, Saskia at IFAASA.co.za. But for tonight, we're going to wrap it up. And I'd like to thank you all for joining us and taking charge of your fertility. Tomorrow, we'll be talking about donor cycles in terms of both sperm and egg donation. As always, you can watch this recording from tonight on our YouTube channel from tomorrow. Thank you to our sponsors for this webinar and our headline sponsors for the week, 360 Biomedicine, helping us to educate more people and break the silence around infertility. But the biggest thank you for tonight goes to Dr. Patel, Dr. Heylen, and to Walter for giving of your time and your expertise tonight. We really, really do appreciate it. And I know that you've all helped somebody out there and made their journey a little bit easier. So thank you very much. Thank you. And take care, everyone, and keep safe.
Thank you, Saskia.
Thank you. Thank you, Saskia.
Pleasure. Bye.